trial was presented looking at tumors that were 3 centimeters or less, lymph node negative, HER2 positive. And the only chemo that was given was 12 weeks of weekly paclitaxel, and it was given with a year of trastuzumab. And they did it as a phase 2 study because they looked at a phase 3 design. They knew this group was likely to do well and that there would be few recurrences, and that to be able to randomize to trastuzumab or not, or to different kinds of chemo, was just not going to be acceptable, and you'd need thousands and thousands of patients. So it was a very interesting design. They said, if we have a very good 5-year disease-free survival, I'm not remembering the exact statistics, but better than a 95%, 5-year disease-free survival, it was somewhere around there, then we're going to accept that as okay not to give anthracyclines, or we can just give paclitaxel. We don't need to give the docetaxel carbo regimen to these patients, and we'll accept it. And they presented really great results, I think, with about 3.5 years of average follow-up, where the disease-free survival was in the very high 90s. I mean, really, they had, you could count on one hand the number of distant recurrences they had. There were more recurrences from second breast cancers or in the same breast, which there was one death due to ovarian cancer, not breast cancer, that counted in it. Amazing results with very little relapse at all. So they're calling it a successful trial, I think, for my smaller HER2 positive lymph node negative tumors. I'm going to give it with weekly paclitaxel. It's far less toxic than the chemo we've been using. And the real question, I think, comes up if they're, half a centimeter or a centimeter, do they even need that chemo at all? Especially if they're estrogen receptor positive. Could I give estrogen targeted therapy and HER2 targeted therapy, omit the chemo entirely? That, of course, wasn't the study, but that's what all the talk was about. Did all of these patients even need the chemo?